morning, Zoe.
Hi, good morning.
Thanks for joining me this morning on BBC Radio Bristol. A lot of stories this morning about cancer, and of course, if I was to have mentioned that word, I don't know, even 10 years ago, it would have that black pall over it, wouldn't it, cancer? Not so now.
Yes, I agree. I mean, obviously, I work in the field of breast cancer, and I myself, together with my colleagues, function as breast cancer surgeons, and we work very closely with medical oncologists and radiotherapists and pathologists. And I mean, obviously involved in clinical research, we try to firstly give patients very clear action plans. So by working as multidisciplinary teams, we're able to bring clarity of information to patients, and it's very much encouraging that clear information so patients have a platform. They effectively get copied into all correspondence. They are very much part of what we call a shared decision-making process. Obviously, in the research field, we are strongly and passionately motivated to keep our radar out on all available clinical trials, which, as you know, in the drug field, have always been at the forefront of high-level research randomization trials. You've heard today on BBC about the new colonic cancer drugs. These are born out of this primary research in the laboratories that takes many years to translate into phase 3 trial studies. And in England, we need to be very aware of how important it is to keep abreast of not only the latest information coming out of the UK, but also from across the pond in the States and other European countries.
There's a problem with these things, isn't there? The problem with these drugs is that they are life-extending. They are not cures. And they cost billions of pounds to develop in R&D, which is why, obviously, the National Institute for Clinical Excellence, NICE, worry about the cost of the NHS, which is already 120 billion quid's worth of expenditure, buying drugs which are only life-extending. They won't cure something like bowel cancer.
Yes, I think the point is that we as a nation need to subscribe, and yes, we do in whatever field of cancer, target cancer organ we deal with, we need to subscribe to all the available National Cancer Research Registered trials, be they derived from Europe or in the UK, because when patients get given the ability to participate in a methodologically robust trial, they get all the advantages of a potential therapy that may either be equivalent or superior. Very rarely is a drug inferior, but of course that could also be a point that we have to take on board, and that is medical progress, and that requires interrogation. But in the context of trial participation, we then get to the evidence that NICE needs to say this is a winner, because at the end of the day, it costs money to actually save money, in the sense that patients' lives aren't just about the buck at the end of the day, but as you quite rightly say, we're trying to rationalize the most appropriate combination of therapies, and sometimes those combinations can enhance current gold standard drugs that we use.
The difficulty we face now is that Western illnesses are more likely to kill you than old age. Cancer being one of those illnesses is more likely to kill you than the fact that you're 85 and you just worn yourself out. So how much money do we throw at this?
I don't agree, you see. I think because of the advances in terms of earlier detection, actually getting, as you've heard just a week ago, the breakthrough breast cancer and the Marsden group, Professor Roz Eales, together with Alan Ashworth, there was a great article on new genetic tests for trying to pick up tumours early, identifying and stratifying patients in that way, getting patients into prevention studies like Professor Jack Kuzek runs from Barts in London. So, we're moving the barometer to an earlier detection, enhanced imaging techniques, genetic screening, prevention studies, and therefore I would say we have the opportunity to actually convert cancer into a chronic disease as opposed to something that is fatal.
So if you mentioned something there which I think is a story that has been running now for about a month or so, this genetic testing. If you've got £650 million, which is the cancer drug fund, the government's cancer drug fund, which is being used to pay for treatment for some 28,000 patients, including some 1,300 bowel cancer patients in Bristol, should that money not be just diverted into, rather than dealing with the treatment, actually dealing with prevention? Screening you, screening me, and screening every other listener onto BBC Radio Bristol to find out whether you've got cancer or not.
Okay, so what you do is you don't screen everybody. You create hierarchies of patients who, on biological markers, which you've obviously taken time to develop and which we don't have, and you know there's a lot of controversy about, for example, the PCA screen, and many people say men shouldn't have a PCA screen. I'm getting into a field that is not immediately in my expertise, but the point of screening is you will also overtreat, and there's been a lot of controversy about that. It is trying to work out scientifically and on trial evidence who are the patients who are most likely to develop a subsequent event, and therefore we would enter those patients into early imaging studies and prevention studies.
So working on the very basic premise of prevention is better than cure.
Yes, but also the point is, I come back to the point, if we as a medical fraternity in the Southwest encourage trial participation, patients are part of trials where they have the opportunity for innovative drugs without that drug necessarily costing the provider at that point in time, because that is the benefit of the funding that goes into research. Once we accumulate that level 1 evidence, which we call the highest level of evidence, then NICE needs to interrogate all the data and actually look at the trial data and see, does the trial data really match up, and can England afford it? And at the end of the day, if you take a drug like Herceptin that has taken 2 decades to develop, from, UCLA in San Francisco and so forth. I mean, this is a drug that is absolutely saving women's lives who have breast cancer, and it actually has impacted and is a magic bullet together with conventional chemotherapy. That was a drug that obviously had millions and millions of dollars poured into it, but the effect is magnificent. Now, there's maybe only one drug like that out of thousands and thousands, but it's still a question and a quest for continually looking for that drug. And at the end of the day, it's also possible that you may get the odd magic bullet drug, then you will get other drugs that have lower level effects.
Very briefly, Zoe, the problem with that, though, is you've got to fire an awful lot of bullets to find the one magic. You've got to find that silver bullet. And
that is the challenge.
Millions of pounds, isn't it? Millions and millions and millions of pounds.
Yes, but if we partner with international partners in research studies and trials, that is the way forward. It's working smartly and not necessarily for us to try and reinvent the wheel in every sphere. We must learn from our international partners.
We'll leave it there. Zoe, thank you very much for joining me this morning on BBC Radio Bristol. Thanks for your time.
My pleasure.
Call John 0845 900 5949. BBC Radio Bristol.